Hello, welcome everyone to HRS TV. I'm Jeanne E. Poole. I am the editor-in-chief of the Heart Rhythm O2 Journal. Today, we bring you an interview with two of the co-authors of a paper publishing in our Global Voices section. The title of the paper is Outcomes and Care Quality Metrics for People Living with Rheumatic Heart Disease and Atrial Fibrillation in Uganda. I'd like to introduce who is with me today. First is Dr. Srivatsa. She is our section editor for Global Voices within HRO2. I'd like to also introduce two of the authors on this paper. Chinonso, I'll start with you. This is Dr. Chinonso Opara. You can raise up your hand there, Chinonso. Chinonso is originally from the Federal Republic of Nigeria. He attended Vanderbilt University for medical school, followed by internal medicine and cardiology fellowship at the University of Washington. So I've known Chinonso now for a while. I'm very excited to say he'll be joining our EP fellowship group in the next year at the University of Washington. Dr. Opara has many awards from his years of education and training, and I wanted to make a note that he received the very coveted University of Washington Cardiology Fellow Teaching Award in 2022. He has participated in the University of Washington Harborview Medical Center International Medicine Clinic. He's involved with the ACHI Association since 2000, which is an initiative founded by citizens in his home village in Nigeria. And the purpose of that initiative is to enhance community well-being through improved infrastructure and health care. He also has spent volunteer time in Kenya working in the outreach healthcare program. He's already co-authored a number of peer-reviewed papers with both U.S. colleagues as well as those in Africa, and many of them focused on rheumatic heart disease. I'm going to turn over to you, Chris. This is Dr. Chris Longenecker, who is also faculty at the University of Washington. He comes from Pennsylvania, attending medical school at the Ohio State University College of Medicine. He then completed internal medicine residency at the University of California, San Francisco, and cardiology fellowship at the Cleveland Medical Center. He then stayed on as faculty at Case Western Reserve. He additionally completed the Global Clinical Scholars Research Training Program at Harvard Medical School between 2015 and 2016. In 2021, we were very fortunate to have him join the faculty at the University of Washington in his current position as Director of the Global Cardiovascular Health Program. He also has had multiple awards throughout his career. He's mentored numerous trainees, including healthcare providers in Uganda, where he has spent significant time. He facilitated the mentoring program for the Ugandan Masters of Medicine and PhD students enrolled in the Medical Educational Partnership Initiative at Makerere University in Kampala, Uganda. He has published over 170 peer-reviewed papers and gives frequent lectures locally, nationally, and internationally. So welcome, both of you. We're really very excited to have you today. And I'm going to turn it over to Uma now, and I think we're going to hear a little bit about the actual paper.
Hi, Chinonso, and hi, Chris. Thank you, Jeanne, for that introduction. Very nice to meet you all online. I was very impressed with your paper, Chinonso. It's a pretty good effort, and we are always looking for papers from all over the world, and we were so impressed of something from the African subcontinent. So tell me a little bit about your background, about how you got connected to Kampala, Uganda, and summarize, please, about this registry and what are your findings and where would you like to go from here?
Yeah, thank you very much. So like Jeanne mentioned, my background is in Nigeria, and I think that we have a lot of connection there. And I think having moving to the United States, we want to continue to find ways to give back to the subcontinent that we come from, and so over the course of my training, I got acquainted with the group in Uganda, and it's particularly the Uganda Heart Disease Registry, which was established around 2009, 2010 timeframe. And so we've had a number of opportunities to study rheumatic heart disease within this context. And I'm just going to give a brief summary of our findings within the context of the Uganda Heart Disease Registry. And so, as we understand, rheumatic heart disease is a leading cause of morbidity and mortality in many of our resource parts of the world. And atrial fibrillation, which itself is associated with adverse cardiovascular outcomes, is the most common arrhythmia seen in rheumatic heart disease. And despite this, there remains a paucity of data in this population to help guide policy interventions to improve outcomes. And so our aims were to understand the demographic and clinical outcomes of people living with rheumatic heart disease and atrial fibrillation within the Ugandan context. So we conducted a retrospective analysis of the Uganda National Rheumatic Heart Disease Registry between June 2009 and May 2018. So we included 1,530 participants in this analysis, and 293 of those were in the AFib group. The median age in the AFib group was 44, and this compares to 23 in the non-AFib group. The AFib group tended to have more severe heart failure, more history of prior stroke, and more severe mitral stenosis. And 79% of the participants in the AFib group reported being on anticoagulation, and warfarin was the only anticoagulation prescribed within the cohort. So over a median follow-up of 203 days, overall mortality was 3%. And we found that AFib was not associated with excess mortality, which was a surprising finding for us. We also described the rheumatic heart disease treatment cascade within the cohort. And in this cascade, we define being retained in care as a self-report of having been seen in clinic within the last 12 months. And adherence to penicillin prophylaxis was defined as taking at least 80% of prescribed penicillin doses. Using the overall sample size as the denominator, we saw retention in care was very low at 13% for the overall cohort. However, when we zoom in on the AFib group, retention in care was 18%, and this compares to 12% that were retained in care in the non-AFib group. And so we found that this 6% difference in retention in care to be statistically significant. And also, from a real-world perspective, this is also clinically meaningful. And among the AFib group, we found that being prescribed anticoagulation was independently associated with an 86% higher odds of being retained in care. And now, our group's prior work with the Uganda RHD registry demonstrated a mortality benefit trend of being retained in care, and with a statistically significant survival benefit of being retained in care and optimally prescribed penicillin. And now that benefit may have been more driven by the impact of having more intimate medical follow-up rather than by penicillin just by itself. And then we also found that factors associated with reduced retention in care were being of male sex, having more severe heart failure, and importantly, living farther away from the center where they received RHD care. Equally importantly, we have previously shown that participants in the Uganda RHD registry take on significant levels of direct medical and direct non-medical costs associated with the high price of medications and transportation to a medical center. And so our key findings are that, number one, in the Ugandan context, people with RHD and AFib do not have higher excess early mortality than those with RHD who do not have AFib. And number two, people with RHD who also have AFib are more likely to be retained in care. And we have previously demonstrated the mortality benefit of retention in RHD care. And number three, being prescribed anticoagulation was strongly associated with being retained in RHD care. So overall, we hope that our work will continue to contribute to future policy interventions to enhance retention and care in this population. And such interventions may include continued decentralization of RHD care to include health centers that are more proximal to patients with RHD, and possibly reforms to mediate out-of-pocket household expenditures related to rheumatic heart disease.
Thank you, Chinonso, for that nice summary. It was very well elaborated. So, question is, the retention of care was still under 20%, right? In your paper. So, and do you think that's because of education or distance? Is there finances involved for medical care of these patients?
Yeah, I think a lot of that, I think all of the above. And I think that I think that all of the above, we had a prior study that, when we looked at the direct medical costs, whether that's the cost of medications, cost of lab tests, direct non-medical costs like transportation and food, you know, all of that has a role to play in it. And not to mention, um, although most of our participants received care directly in Kampala, we still had some regional healthcare centers. And I think that there still needs to be more work done to regionalize the RHD care so patients don't have to travel as far in order to mitigate some of the direct non-medical costs associated with receiving RHD care. So all of the above, that's why we do these studies so that we can help to inform policy interventions to improve care in this population.
Right.
Yeah.
And so the time in therapeutic range or, on the patients with Coumadin was pretty low as well, right? Like about 40%. The national average here is about 70%. Of course, we have so many well-established Coumadin clinics, warfarin clinics, anticoagulation clinics, as they're called now. How is it there in Uganda? And then is this hospital, this institute, a government-funded institute? Is it free for all care or is it pay for service? Please educate us about that.
Yeah. Yeah. So, um, uh, I'll let Chris talk a bit more on the funding sources, since it's not as intimate to my knowledge as possible. And so, Chris.
Yeah, happy to jump in here. First of all, I want to acknowledge the Uganda Heart Institute, our primary partner in Uganda, and the tremendous strides they've made over the past 15 years or so. Not only in partnership with us, but many, many partners around the world. And so, there are various sources of funding. The Uganda government actually does provide support for the Uganda Heart Institute as a semi-autonomous kind of organization within the healthcare infrastructure of Uganda. But they've also taken the approach that people living with rheumatic heart disease are typically the most vulnerable and often do not have the resources for their care. And so in some ways they are able to take money that is made from fee-for-service cath lab procedures, for example, and use some of the funding and the human resources then to care for people living with rheumatic heart disease. So I think that model is novel, and we hope that we can build up capacity across the entire Heart Institute in order to keep this mission-driven care of rheumatic heart disease going.
Yeah, so I was thinking about that too, and thinking about all the conversations Umi, you and I have had, because I think there are a lot of similarities to some of the areas in India that you have worked also, that, it's so vital to have these kind of institutions put together and funded in the multiple ways in which they are funded. But then the next challenge is always, how do you go beyond the patients that are able to access the care at those institutions and those who are not? There's been some really interesting stuff in some lower income middle countries with trying to get mobile units out to patients to do, warfarin checks and that sort of thing. Is there something like that maybe that's going on to try to engage people that live a little bit further distance from the Uganda Heart Institute?
Yeah, absolutely. The idea of decentralization is critical for a country like Uganda. Again, 40 million people, a lot of whom live around Kampala, but many living in the regions that, takes 5, 6, 10 hours to get to the capital city. And so this has been a project of, 10, 15 years of establishing regional centers. And with the support of a grant from Medtronic Foundation, we were able to decentralize from one center of excellence in the capital to multiple regional centers of excellence. the next step then is to go from a regional center of excellence to really into the primary care clinics, the health center threes, the health center fours, district hospitals. And that is the focus of a current project that is NIH funded, an implementation research project called ADUNU, where we're trying to get screening for rheumatic heart disease into the hands of frontline health workers. We can talk more about the innovative approach to that and using AI-guided ultrasound to do so, but really to build up that infrastructure at the primary care level so that people don't have to travel long distances to get specialty care.
So, Chris, on that note, in my former days of working in public service in India, we used to have school health services. Like, are there situations, because these kids who develop rheumatic fever at a young age are those who begin to develop all these end stage issues with the heart. Is there rheumatic fever prophylaxis instituted, active screening at the school level? And by the way, this is really requires a huge congratulations on this partnership, because otherwise this kind of data is not going to come to light. So it's really appreciable.
Yeah, and we have to acknowledge our pediatric colleagues because Chinonso and I and Jeanne E, we're adult cardiologists, and we often see people with atrial fibrillation when they're older, as Chinonso pointed out. But to get to the root of the problem, you're right, it's mainly a pediatric issue. And our colleagues at Cincinnati Children's Hospital and Children's National Medical Center in Washington, D.C., people like Andrew Beaton and Craig Sable really have been the driving force behind a lot of this work. And so absolutely, the community-based program that I just mentioned, trying to improve primary care, is also going into schools and building up structure in the schools to screen for rheumatic heart disease and get children into care through the schools. That's been a long-term strategy. So, ultimately prevention is going to be the most important, because the health system cannot bear the burden of doing a heart valve surgery on people when they have late disease. So getting people into care early to prevent atrial fibrillation, to prevent the progression of disease, I think is important.
Which is kind of what is really important in all cardiovascular disease, right? Prevention, a challenge here in the U.S. as well as abroad. We're getting near to the end of our time, and I really appreciated not only hearing you speak, Chinonso, about the study that you did. I think it's very enlightening, but Chris giving us a few little insights. I'm going to give you each an opportunity to have one last word or message to us, especially as an electrophysiology community. Chinonso, you go first.
Yeah, I think that, if we look at many of the constitutions of African countries, many of them were drafted in the 50s, 60s, or later. I think that while in sub-Saharan Africa, there's still much progress to be made, I think we are relatively still a young place. And, a lot of progress still needs to be made, but we've also come from a long way. And so I really do remain optimistic in the care of that, in the ability to expand cardiovascular care access. And so I think that, we have a long way to go, but we're still a very young community. And so I think that I encourage us to continue, or people in the diaspora, to continue finding ways to give back to the communities where we originate from.
Great. Chris?
And I echo that optimism. I think the progress that has been made over the past 15 years in Uganda is dramatic, and elsewhere on the continent. I think that there's a lesson learned here about the value of registries and how a small project focused on quality improvement can become a much larger effort that leads eventually to implementation research. A lot of what we've learned from the registry is epidemiology, and we know where the disparities, where the problems are. But now we need to figure out how to bridge the gap and really figure out how to deliver care more innovatively with less resources, but do so efficiently, and improve outcomes ultimately with those interventions. So that's where a lot of our group is going towards that implementation research.
So well said. I am very excited that you were able to join us today. This is wonderful. It's exactly what we want to be able to do in the Global Voices section of our journal, is to be able to give voice to those who are facing unique challenges working in middle and low income countries in particular. And I really am very impressed with the work that has been done so far. And I know that you'll be and both of you will be doing great work in the future too. So thank you for joining us. And I'd also like to thank the other authors of the paper, which included two of the African colleagues that Chris and Chinonso know well. And actually, and I had a chance to actually meet them in another situation in the past. So we were very happy and very pleased that you were willing to do this paper and give us the opportunity to focus on it. So with that, we're going to close out, and I'm going to say goodbye to all of our listeners and hope that you really enjoyed this session. And we'll see you again on another HRS TV.
Thank you so much. Appreciate it.
Thank you very much.